Hey everyone, welcome. Thank you so much for joining us tonight. We have everybody on mute because there's such a big group of us, but please feel free to keep your cameras on because we are all connected and we are so happy to have you join us. I've got my team here from the West Coast and East Coast and everywhere in between. I've got Rebecca, she'll wave right there. She's my counterpart in New York. Emmy in San Francisco, Dr. Westfall right there. She's from our San Francisco, our medical director. And then we have Whitney Mixter here right there. Yay, Whitney. Dr. Dovey from San Francisco and Dr. Brower from Los Angeles or Santa Monica. And then we also have Brooke and Cassie from Root Surrogacy Agency. And so we're gonna give everybody till about 5:05 to join us before we get started. But thank you again, everyone, for joining us today. Here we've been booking along on Fertility Awareness Week, and we couldn't be happier to have an opportunity to have an inclusive discussion for LGBTQ and to really have a conversation and go through all of the wonderful things that we can provide, what we call third-party reproduction. And Dr. Dovey will explain a little bit more about that. And then Whitney is going to be so incredibly generous and share with her journey and all that she's gone through becoming a soon-to-be mommy. So thank you. We'll just have a couple more minutes. Feel free if you want to message me. We have the chat turned off for now. We'll turn it on later. But if you want to message me where you're from, I would love to know where everyone's from. I've got Erica Keller right there. She just joined us. And Erica's in San Francisco. She's our PA in San Francisco. Thank you so much, everybody, for joining us. We've got Florida, New York, St. Louis, Toronto, Canada, Arizona, Burbank, going deep west side, Burbank, Tacoma, Washington, Atlanta, Georgia, Louisville, Kentucky, Pittsburgh. My husband is a huge Steelers fan, I'm gonna let you know. Jersey, Los Angeles, Pasadena, Boise, Idaho, Brazil, Rhode Island. Oh wow, Cyprus, 3 a.m. in the morning. Thank you so much. Hayward, Los Feliz, New York, Las Vegas, Venezuela. Thank you so much, Seattle. You guys, we're so truly happy to have you here today. And we're gonna get a little bit more into kind of talking about Kind Body, but our whole purpose in our mission, our core mission in our company is to provide accessible fertility and wellness care for all. And in this discussion, we're gonna do our very best to be inclusive in the language that we utilize. But just know when we're speaking about male or female, it truly is about the reproductive organs, because we are talking about the birds and the bees and making babies. So we have to be able to have the conversation to explain kind of what tests are needed for what person. But know that truly all of us are here to provide fertility care for all. And our team has been so happy to be able to have this conversation tonight. And when I first met Whitney, from the moment I met Whitney, Whitney was on board and so excited to be able to do this and to be a part of this conversation. So I'm incredibly thankful to have her here as part of this conversation. So we're gonna get started in just one more minute. We have someone from the Ukraine, Colorado. Dr. Dovey's from Colorado, so she'll give some love to her Colorado brethren and sistren. Okay, so I think we can get started. I really want to, again, welcome everybody for coming today, and we're excited to get started and have this conversation. I'm going to start by introducing Dr. Meredith Brower, who is our physician in Santa Monica. And let me unmute. Oh, you're not on mute. Wonderful. So go ahead, Dr. Brower. So sorry.
Great. Thank you, Tracy. And I just want to reiterate, thank you to everyone who's here joining us. And thank you to Whitney and to Root Surrogacy for being a part of this discussion. So we've taken this week to try to provide all kinds of information. And tonight we get to talk about LGBTQ family building. And so what I'm going to do is I'm just going to give you a really brief introduction to Kindbody and what we do here. And then Dr. Dovey is going to talk a little bit about family building for males. And again, just to reiterate what Tracy said tonight, when we say male or female, we're not just talking about gender or identity or orientation. We're just talking about which reproductive parts you have, and so that we can talk to you a little bit more about, which other ones you might need. So it's strictly just about reproductive physiology when we use those terms tonight, to be clear. So Kindbody is, we offer the full spectrum of fertility care. Serena, do you mind? Serena, can you flip the slide? Yeah. So we have clinics in New York, San Francisco, and LA right now, plans to expand further, but we offer full spectrum fertility care. And we try to do it in a modern way. And what we mean by that, we try to make our care accessible, affordable, and approachable. Our clinics, we try to make the environments friendly and warm, and just sort of pleasant places to be. So that's, a huge part of our mission here. So I think the next slide just kind of lists some of the services that we provide, but we really do provide everything from preconception counseling for people who are anybody who's planning to get pregnant, to evaluations, fertility evaluations, inseminations, IVF, reciprocal IVF, all third-party reproduction, which we're going to talk a lot about tonight, assisting with egg donation, sperm donation, embryo adoption. So, and then we provide a lot of support services too. We pride ourselves on taking a holistic approach to patient care. So we offer nutrition counseling, we promote other emotional support counseling, and so we, again, offer that all through Kindbody. And I'm going to let Dr. Dovey take it away. She's our wonderful physician in the San Francisco office.
Okay. All right. Well, thank you guys all for joining us tonight. It's great to have so many people here. And I'm just going to start by just kind of talking a little bit about what I would call the traditional reproductive process, which is just to kind of orient everybody to, like we will talk about sort of what is necessary to create a human baby. Generally speaking, in the ovary, obviously women have eggs in the ovary, and so every egg is encompassed in what we call a follicle, and basically all a follicle is the egg and then support cells around the egg that help it grow. And so you have a variety of follicles in the ovary that are growing at various stages, and every month a woman is going to select one follicle will grow and be selected as the dominant follicle and actually release an egg every month. And that's governed through hormones from the pituitary gland, the process of ovulation, release of the egg. And then once the egg's ovulated, the fimbriated end of the fallopian tube, which is like the finger-like projections at the end of the tube, will basically pick up that ovulated egg. And then in that particular cycle, if there's sperm in the reproductive tract, either through sexual intercourse or through an insemination, the sperm can swim out to the fallopian tube, and if it's present here in the tube at the time of ovulation, then there's the capacity or possibility that the egg would become fertilized. So fertilization traditionally happens in a fallopian tube, and then a fertilized egg for the next few days basically will undergo cell division to turn into a more advanced embryo that we call a blastocyst, and that's this one here that I'm indicating. The blastocyst generally develops about 5 to 6 days after fertilization and is differentiations to two different components. This inner cell mass here, we call that's the inner cell mass, and that's ultimately actually what becomes the baby. And then these outer cells here ultimately become the placenta. And so it's the blastocyst stage that an embryo will then implant into the uterine cavity to create a pregnancy. So that's just to orient everyone, to go back to biology 101, since it's probably been a long time since anyone really thought about the actual steps of what it takes to become pregnant. And actually is a fairly complex process if you think of everything that needs to happen for an embryo to actually implant in the uterus. But as you can see from that past diagram, there's basically three main building blocks to creating human pregnancy. We need sperm, we need eggs, and then we need a uterus. And because we have not quite yet been able to create artificial wombs where we can put embryos and just develop them outside the body, generally when we talk about a uterus, it's within a female. Okay, so for anybody who's considering family building through third-party reproduction, and what we mean, third-party reproduction is just a medical way of saying that someone may require a sperm donor or an egg donor or a gestational carrier or some combination of that in order to have a family. So for single or same-sex female couples, if you're looking to build a family, we'd have you come in and have a personalized fertility consultation with one of our providers and undergo a fertility evaluation. For single or same-sex male couples, we also like to meet you in the office for a personalized consultation and go through your medical history, and can talk specifically about going through IVF with the use of an egg donor and a gestational carrier. Okay. Oops, sorry, I think that I just skipped a slide here. There we go. Okay. So we're going to talk first about, the first part of this talk, we'll talk a little bit more about same-sex male couples or single men who are interested in having a family. So like I just mentioned in the last slide, the first thing is always we always want to know more about a man's medical history to know if there might be any chronic medical issues or anything that might impact the capacity to make healthy sperm and to have a baby. So any chronic medical conditions we'd want to know about, medications men are taking. One thing I always like to ask about is whether men smoke cigarettes, because we actually know smoking is one of the lifestyle factors that really can negatively impact both male and female fertility. And so that's something we'd recommend quitting for anyone who is smoking. And then finally, it's also important, I always like to know if men are currently using any type of testosterone or anabolic steroids, because those can also substantially deplete sperm production. And then in terms of male fertility testing, basically the cornerstone of male fertility testing is going to be to do a semen analysis. And there's a variety of parameters that we look at on a semen analysis to better gauge whether a man may be fertile or not. So some of the specific things we look at on a semen analysis are going to include the semen volume and whether there's enough ejaculate there. And generally you'd expect over 1.5 mLs of ejaculate. We look at the sperm concentration. That's basically asking the question, how much sperm are the testicles actually making, and is that a normal amount? So again, we generally like to see at least 15 million sperm per ml, but that concentrations can vary quite a lot. You know, some men might make more 50 to 100 million sperm per ml. We look at how well the sperm swims, and that's the motility parameter. And that's basically making sure, as you could see in that first diagram I showed you, sperm does need to be able to swim up through the reproductive tract in order to find and fertilize the egg. So the motility component lets us know if enough sperm are swimming well enough that we think that they should be able to get to the egg. And then finally, we look at the morphology, or the shape of the sperm. And that's really kind of a characterization of the shape of the head of the sperm, because that has some implications on how the sperm might bind to and actually fertilize an egg. And as you can see, since millions of sperm are made in the testicles every day, we don't expect a huge percentage of them to be normal. We grade it on a fairly strict scale, but generally you'd want to see more than 4% of the sperm having a normal shape based on some strict criteria that we grade that by. Okay. Oh, I'm sorry, for some reason I keep going the wrong direction. Okay, So once we've met with a man who's interested, or a male couple who are interested in having a child, and evaluated their medical histories and semen parameters, the next thing is to look at selecting an egg donor. So when we think about building a family for a same-sex couple, a same-sex male couple who needs to use an egg donor and a gestational carrier or a surrogate, I always like to just, it's a lot, seems like a lot of a complex process. I think it's helpful just to break it down into two like sort of concrete steps. The first one is creation of the embryos. And then the second step is going to be identification and screening of a gestational carrier, where we can place the embryos once they're created. So I'm going to talk first about selection of or creating embryos. And the first step of that is selecting an egg donor once we've evaluated whether we have healthy sperm through the semen analysis. So there's a couple of different decision tree factors in terms of selecting an egg donor. And again, like Meredith said at the beginning, this can really apply, when we talk about egg donors, it doesn't necessarily just apply to same-sex male couples. You know, there's a variety of medical reasons that many medical situations where people may consider using an egg donor, and this would really apply to anybody. So the first question to ask when you're thinking about selecting an egg donor is, are you going to use an egg donor who's anonymous to you, who you would work with an agency to sort of recruit and find the donor, or do you want to use somebody who you personally know? So, you know, some men might want to use a friend of theirs or use a family member, something like that, to act as their egg donor. They, you know, want to have that known connection to the egg donor. So that we would consider a known donor, and versus an anonymous, where you either work with an agency to identify a donor. And then for people who are going to use an anonymous egg donor as the source of their eggs, then the next question to ask is, okay, are we going to use a quote unquote fresh egg donor, or would we utilize frozen eggs? And basically what that means, so using a fresh egg donor basically involves working with an agency to find and recruit the donor, and then she would basically undergo an ovarian stimulation process and retrieval of eggs, all of which that person or that couple working with the donor would have at the end of the cycle to make embryos with. And traditionally, you know, a donor in her 20s might harvest 10, 15, 20 potential eggs in a single cycle. And so you might have, there's generally several eggs available when you're doing a fresh donor IVF cycle. The other option is to use an egg bank, where eggs have actually been frozen and are actually donated and to the bank to be used for reproductive purposes. So, you know, obviously for decades and decades, we've had sperm banks in the country that single women or same-sex female couples can go to get sperm and to have a family. And over the last decade or so now, we actually have the capacity to get eggs from egg banks, because the capacity for us to freeze and thaw eggs successfully and have a high survival rate and good pregnancy rates from frozen eggs has really improved substantially over the past decade. And so for women who are interested in being egg donors, what they may do is just work with a frozen egg bank and go to an IVF practice where they go through a stimulation cycle, have their eggs harvested and just frozen without having a specific intended parent in mind, where they're going to donate to, but they just be donated to the bank. And then basically the bank works with a variety of intended parents around the country that can purchase anonymous eggs from that bank. So those are two different options to consider when you're selecting an egg donor. To go back to the first option for a moment, I just wanted to, for anyone who's thinking of using a known donor, one of the most important things really to look at and to think about in selecting a known donor is how old they are. You know, there's a lot of parameters that go into female fertility, but really the most critical generally is age, because we know that female fertility is tightly linked to our age. And as you can see from this graph, basically what this is showing here is that the success rate for live birth through IVF from women at different ages. So you can see here, if we look in the 20s, we have pretty good pregnancy rates through the 20s and early 30s. But then once we hit our mid 30s, the pregnancy rates really do start to decline pretty notably through the later part of the 30s and certainly into the 40s. And this is a comparison to women who use donor eggs, which is this blue line here, which you can see if you're using a donor, an egg donor, or sorry, eggs from a donor who generally egg donors are going to be under age 32, the pregnancy rates really stay stable regardless of how old a woman is when she's giving birth, if she got pregnant with an egg donor. And so that really just speaks to the fact that it's really the age of the egg that is the most critical determinant of the likelihood of a healthy pregnancy, and not necessarily just the age of the woman giving birth to the child, because it's not necessarily the age of the uterus so much as the age of the egg. So just to highlight the importance of when you're using a known donor, we generally would recommend trying to select a donor who's 32 or younger just to optimize the chance for success. And then just as a quick aside, we talk a lot in a lot of the fertility talks we give about female fertility and how much that is linked to age. But I think something that we don't talk about as often, but I think is an interesting point, is whether male fertility declines with age too. And the simple answer to that is yes, it actually does. So men don't have completely stable fertility throughout the duration of their lifespan. There are studies that do show that ejaculate volume, sperm morphology, and motility do decline with age, and this does lead to a decrease in semen quality. And one of the interesting, I think, delineations between female fertility and male fertility is this factor here. So, women, we say this a lot, women are born with all the eggs we're ever going to have. We have a very finite fertility window, and once we completely run out of eggs, the ovaries basically become non-functional. They don't make hormones, we don't release any more eggs, and that's defined as menopause. Whereas for men, there really is no there is no state of age that they reach where they go, where the testicles just stop working. And that's because basically men have stem cells, we call those spermatogonial stem cells in the testicles, that basically are able to divide and make new stem cells throughout the whole man's life. So the sperm source is never depleted. They can always divide and make more stem cells to make sperm. And that's why men are actually able to make sperm throughout their whole life. But one of the reasons that fertility can decline in men over time is that, if you take a man who's 21 and fathering a pregnancy, the stem cells in his testicles haven't had to divide as much to keep that stem cell pool complete. Whereas if you look at somebody who's fathering a pregnancy at 50, his stem cells have gone through many, many, many more divisions in order to keep this stem cell supply complete. And so that's every time a cell goes through a division, it has to replicate its DNA, and there's always a possibility of having an error made. And so that's how genetic errors can be introduced, and why we see some more genetic abnormalities linked to advanced paternal age. So anyways, that's just an aside, but I just think it's interesting because people, I don't think we talk as much about how male age can impact fertility. Okay, so going back to the question of fresh eggs versus frozen eggs. So for those who choose to use an anonymous egg donor, some of the things just to consider in making this decision would first be, how many children do we want? And I sort of referred to this earlier, but if you use a fresh egg donor who's going to go through a stimulation cycle and have all the eggs retrieved, you may end up with somewhere between 10 to 20 or more eggs, and that is going to ultimately create multiple embryos. So for a same-sex male couple, if they're thinking they really want 2 or 3 kids, generally it makes a lot of sense to use a fresh egg donor, because you're going to most likely be able to create multiple embryos in that one cycle, so that you can have multiple pregnancies from that one cycle. When you use eggs from a frozen egg bank, the egg banks have basically figured out about how many eggs a person needs in order to have a realistic chance of having a live birth from those eggs. And the number generally is around 6. So they generally sell them in packages of 6. And so if you work with a frozen egg bank, you'll generally buy a package of 6 eggs. And ultimately, you're most likely only going to have maybe 1 or 2 embryos to transfer from that cycle. And so there's not as high a chance of having more than 1 child from using 1 batch of frozen eggs. Certainly you can buy more, but then it can become more costly that way. So, but one benefit of using frozen eggs, especially if you're just planning 1 child, is that because donors are kind of recruited from all over the country to different egg banks, oftentimes there might be a bit more variety in terms of selecting a donor. And then the second question to answer or to ask is, are we planning to do genetic testing? Generally speaking, if you have a fresh donor undergoing a cycle, again, we'll have multiple embryos to do genetic screening on to determine which would be the best embryos to transfer and give the best odds for a healthy pregnancy. Whereas if you're using 1 batch of frozen eggs, you may only have 1 or 2, and the need to do genetic testing, that situation may not be as important. Okay, so what is IVF? Once we've decided on our donor, if we have either a known donor or an anonymous donor going through a fresh cycle, basically what she would do is she would administer hormone injections for about 10 days to help a batch of eggs mature through the IVF cycle. And then she would come into our office on a regular basis, generally every 2 days or so, so that we can do ultrasounds and blood work monitoring to make sure that she's responding to the medications well, the follicles are developing well, and we can make any adjustments as necessary. And then once we see that enough of the follicles have gotten to a size we think most would be mature, we would give a final injection called a trigger shot to allow the eggs to finish the maturation process in the ovary. And then 36 hours later, the egg retrieval is done. And this is just a minor procedure. It takes about 15 to 20 minutes where we put an ultrasound probe through the vaginal wall and into the vagina, and basically you can pierce a needle through the vaginal wall right into the ovary as pictured here. And the needle is hollow and basically just suction the fluid out of each of those follicles. And the egg, if it's matured appropriately, is usually floating there in the fluid and will be removed with the fluid. And so basically we would harvest eggs that way. And the donor is put under a light anesthesia for the short duration of the procedure. Okay, so on the day of the egg retrieval, we also need a sperm to fertilize the eggs. And so if you have a same-sex male couple, either one or potentially both, a lot of couples like to both use their sperm to make embryos from each of their sperm sources. So we would collect sperm from either or both of them to fertilize the eggs. And then the fertilized eggs would be monitored for the next 5 to 6 days to see how many turn into more advanced embryo here called a blastocyst. And then if you are planning to do genetic testing to look at the chromosomal makeup of the embryo, this is the point once the embryo has reached the blastocyst stage that biopsy could be performed with the genetic testing. And then at that point, generally the embryos would be frozen. Okay, so just a little bit here about genetic testing. What do we mean when we talk about genetic testing on embryos? By and far, most commonly what we're talking about when we talk about genetic testing is something that we call pre-implantation genetic testing for aneuploidy. And we abbreviate that PGT-A. And really what it means is that on that blastocyst embryo I just showed you on the last slide, we're able to take 4 or 5 cells out of the area that becomes a placenta and basically send them to a genetic company where they can look at the chromosomal makeup of the embryo to let us know if the embryo is chromosomally normal or not. And this graph just kind of shows the importance of that, especially when we're utilizing eggs from older women, because the chance for chromosome abnormalities increases as we age. So this green graph here just shows what percentage of embryos that are biopsied are actually genetically or chromosomally abnormal. As you can see here, egg donors, even in egg donors, which are sort of the most fertile population, if you will, about 35% of embryos still would be abnormal. But, and then as you get older, as women get older, as you can see, as we progress through our later 30s, the percentage of chromosome abnormalities we see increases. And that's just due to the declining health of the eggs as we get older. And the blue bar here basically just shows what percentage of the time do we have at least one normal embryo to transfer back. And again, when you're using egg donors, virtually all the time you should, but almost 100% of the time. And then, but as we age, for women who are over 42, generally 1 in 3 or fewer would have a normal embryo to transfer back. Okay. So that basically talks about embryo creation. Now I'm going to talk a little bit about finding a gestational carrier or a surrogate, as terminology we often use in the media and whatnot. So many individuals and couples will work with an agency to help find and screen potential gestational carriers. And there are some medical requirements we like to look at to determine whether someone is an appropriate person to be a gestational carrier. Generally, we always want to make sure that someone who is considering being a carrier has been pregnant at least one time and has at least one child. And that's because there is some inherent risk to pregnancy. We wouldn't want someone who's never been pregnant before to act as a carrier and then have some medical complication where she has a hysterectomy with pregnancy. Very not common, obviously, at all, but it is a possibility. And so that's one of the reasons for that requirement. We want women who are looking to be a gestational carrier to not have any major pregnancy complications in their previous pregnancies. Generally, we want for them not to have had more than 5 total deliveries or 2 C-sections, just because the risk of pregnancy can increase in situations with higher birth number. Generally, like for women to be healthy without major medical issues, and then generally also not have a history of alcohol, drug, or alcohol or drug abuse. Okay, so how do we screen a surrogate or a carrier? If we identified someone who is a possible gestational carrier for intended parents that we were working with, we'd have them come to the office and do a history and physical for them to make sure they're generally physically healthy. Generally, there's blood testing that we do to assess hormones that are important in pregnancy, as well as look at prenatal labs. We like to evaluate the uterine cavity, and that's what this little ultrasound picture here shows, is a woman undergoing what we call a saline infusion sonogram, where we put a catheter in the uterus and put some saline in. And that just allows us, rather than doing an ultrasound where the uterus is flat, it allows us to open the uterus up a little bit like this, just to determine if there's any polyps or fibroids or anything structural within the uterine cavity that might impair the implantation of an embryo. And then we also require anyone who is considering being a gestational carrier to undergo psychological evaluation as well. And then finally, one of the final pieces is that once intended parents have identified someone they want to be their surrogate or their gestational carrier, we do require a legal contract be drawn up between the intended parents and the carrier before doing an embryo transfer. And each party, the carrier and the intended parents, need to have their own lawyer. And the main things that we want to address in that legal contract are, compensation for the carrier if coming through an agency, and also just the financial responsibilities of intended parents. Make sure that the carrier is going to have medical insurance to cover the pregnancy. We want to clearly address the rights both of the intended parents as well as the carrier, kind of discuss expectations for ongoing contact between the carrier and the intended parents once a pregnancy has been established, and also just guidelines in terms of the carrier's lifestyle and what to expect at the time of birth. And then also just kind of delineate plans that all parties will agree on, just in case something goes wrong. Obviously, when we're talking about medicine, we can never 100% predict exactly what will happen with a pregnancy. So it's good to just talk about the what ifs so that everyone's on the same page. All right, so I'm going to turn this over here to Brooke from Root Surrogacy for a minute to talk a little bit about their surrogacy process. And Brooke, I'd love for you to talk to us a little bit about how you counsel intended parents on like what sort of factors to look at when intended parents are looking to how they should try to select a carrier.
Sure. Thank you so much for having us. We're so excited to be here. Good to see some familiar faces and Kind Body team. So as far as surrogacy is concerned, it is a really linear process. And I think Dr. Dovey just explained it. We need a psychological evaluation. We need a medical evaluation. We need a legal contract. And those are kind of the nuts and bolts of things. But more so what we're really hoping for is that we can connect people who have this ability to create an organic friendship over time. And in the end, we're looking for, my friend is having a baby for us, and I'm having a baby for these people, my friends. So in doing that, we look at not just the components of what the expectations are. Sometimes parents are looking at the geography of the surrogate, how much time are they going to need to take off afterwards. So if she lives in a place that's farther away from them, do the parents have the ability to take off time to go to the birth, right? Do they want to attend every medical appointment during the OB period of things? So she would need to be closer. So we look at the expectations from both the surrogate and the parent, but we're also looking at really trying to understand who the parents are and who the surrogate is, so that when we connect to those people, they're able to have this organic friendship that is really important, because ultimately it does come down to trust, and there are legal agreements, and honestly, things don't go wrong very often. But you also want to really like this person. It's the birth story of your baby. And so you'd love to have this really warm and an emotional response to the person that helped you create him or her or them.
Awesome. Thanks, Brooke. And what are some of the common fears of intended parents when they're looking to use a gestational carrier or surrogate?
Well, pre-COVID-19, I can talk about that. Now it's COVID-19, but pre-COVID-19, we hear a lot of the times when you first start out in surrogacy, it is, surrogate's going to abscond with my baby and leave and move to Costa Rica, and I'm never going to see them again. It never happens. Literally never. There's a lot easier ways for a person to get pregnant than to go through all of this and to end up with somebody else's child. Mm-hmm. Also, they already have their own kids, right? So all surrogates are moms. So it is, that fear is a little bit, once you cross that hurdle and you're like, okay, that's not really what we should be nervous about. There are components about the relationship that people can be nervous about. You're trusting somebody who essentially is a stranger when you begin with the most important thing in your life, right? So it can be really, parents can feel very nervous about that. I think one of the things that we talk about a lot with parents is that surrogates feel an immense amount of responsibility. So when I have my kids at the park, will I let them climb to the top of the swing and jump off? Yeah, it's fine. If I have my girlfriend's kids, they're not going on to the top, right? Like, it's my responsibility to take care of them. And so surrogates feel a lot of that too, a lot of responsibility and a lot of pressure to make sure that they're doing everything appropriately. And there is a lot of steps in surrogacy. It's not how they got pregnant, right? Mm-hmm. And so there are a lot of responsibilities, self-injected medications and making sure that you have enough medications, and talking about to the whole world about when your cycle starts, and trusting an agency. So there's a bunch of components about being a surrogate, but I think ultimately it really comes down to, for parents, if they're really looking to feel comfortable, it really comes down to picking the right doctor and team to start your process, and then also finding an agency that you trust and that has your best interest in mind. Then once you knock out the embryo portion of things, that's kind of a big checked box, and match with your surrogate, then will have your team in place who can then guide you. Because at the beginning it seems really complicated, and there's all these moving pieces, and there's doctors and lawyers and all these things. And so once you get those two key components in place, I think people feel much more confident about the process and have much more education and information to be able to sort of trust in the process and what's going to happen next.
Yeah, absolutely. I think in my experience, for all the patients I've had who've used a surrogate, I think you're right. Like, once we have the embryos in place, and once we know the surrogate and she's going through screening, everything seems to really simplify. And then at that point, really all we need to talk about is how to get that embryo inside of her uterus. So it becomes a much more simple process at that point. So awesome. Thank you so much for being here with us.
Thank you.
Yeah, of course. All right, well, I'm going to finish up here. So just to complete the talk about the process that we've been talking about using, creating a pregnancy with an egg donor and a gestational carrier. So again, once the embryos are created, once the carrier is screened and ready, we can perform an embryo transfer. And simply all an embryo transfer is, this is an actual picture of a woman having an embryo transfer from an ultrasound picture. And this white line here is a catheter that we just place through the cervix and into the uterine cavity. And then you can see here, these two little white dots are actually two little air bubbles around the embryo that were just transferred right into the uterine cavity. And we always do this under ultrasound guidance so we can see exactly where the catheter is and where the embryos are placed, the specific location in the inside the uterus where we're aiming to place them. But yeah, overall, it's really not more invasive than a pap smear. So. And then in 10 days, we can check to see if the embryo has implanted, and hopefully we get our final product at the very end, which is a healthy baby. So, all right, I am going to turn the slide set over to Dr. Meredith Brower now so she can talk a bit more in detail about reproductive options for same-sex female couples.
All right. Can you see that? Okay, great. Thank you, Serena. That was great and super thorough. And I have Whitney here, who is also an expert in family building, female family building. So she is going to help me explain to you the process of family building for LGBTQ females. And a lot of it, there will be a lot of overlap from what Dr. Dovey just explained. So we won't go into too much detail, but again, just to go back, you know, it's always important to think about what are the basic building blocks for a pregnancy to occur. And to state the obvious, as Dr. Dovey just said, we need sperm, we need eggs, and we need a uterus. So a lot of what Dr. Dovey was explaining is, well, if you have sperm and you don't have an egg or uterus, what are the steps? And so for most females, they will have an egg and a uterus, but not sperm. So that a lot of this part of the talk will be focused on obtaining sperm for reproduction. So just to start, everything always starts with an assessment, right? So the first step is always, and Dr. Dovey touched on this too, for us to understand, for you guys to do an assessment, whether right now it's virtual, someday again it'll be in person, but for us to understand who you are, okay, what's your current situation, what, you know, who are you medically, who are you personally, and what are your reproductive goals? And so we kind of need to understand that so we can sort of help you come up with a plan that is personalized to you and who you are and what your reproductive goals are. So again, I won't go too much into this. Dr. Dovey did a really beautiful job explaining the process of natural ovarian aging. So again, all females are born with eggs, and we're born with all the eggs we're ever going to have in our ovary, and we lose them over time, and the quality of those eggs decline over time. And Dr. Dovey showed some really nice graphs to sort of depict that. But age is a very important prognostic factor in understanding female fertility. It's not everything, but it is important, and egg quantity is something we can measure. So when a female comes in and she's desiring to start family building or to procreate, we will assess the eggs. And when we do that first by assessing egg quantity. And we do that with a combination of ultrasound and blood work. Egg quality is not something we can assess. So part of this process of ovarian aging is related to the loss of eggs, and that's egg quantity. And part of it has to do with the decline in the quality of the eggs. And unfortunately, as I just mentioned, we can't measure that. So in a female who is still getting periods and ovulating regularly, every month she releases one single egg. in the middle of her cycle. Sometimes she releases a normal egg, and sometimes she releases an abnormal egg. And that's true for everyone. Dr. Dovey just told us even egg donors who are 25 years old sometimes release abnormal eggs. And that is egg quality, is, well, what percentage of the time are you releasing a normal egg? And we can't measure that directly, but we know for sure that that declines with age. And in a cycle where a female releases an abnormal egg, either typically a pregnancy won't occur, or a pregnancy could occur and a miscarriage occurs, which is why we see as women get older, both the rates of infertility go up as well as the risk for miscarriage. And that's all related to that sort of egg quality component. So when somebody comes in, as I said, we start to measure their ovarian reserve, which is egg numbers. And so, Whitney, correct me if I'm wrong, I believe when you first came in, right, we did an ultrasound, we did some blood work. Do you remember anything about your follicle? Can I ask you anything? Can I ask you, do you remember anything about your follicle count, your AMH? Can you tell us tell us a little bit about your experience with the initial visit and assessment? Was this the first time you had heard this information? Did you know this already? What do you remember about your ovarian reserve?
Yeah, I mean, this was all news to me, really. I mean, you hear about your reserve going down. You have this kind of looming thought of just like this pool shrinking and shrinking, but like, what does it all mean? I mean, I didn't know like I had to go in during my cycle. I didn't know anything about it. I didn't know about follicles and what a follicle was. And it's like, why are we not taught about this in school? I have no clue. You know about eggs, but hearing about follicles was news to me. So yeah, when I went in, I had my assessment done, and I had, so they check to see how many you have on each side. You have to correct me because it was a long time ago now. And, but I had, I think like 8 on one side, 8 follicles on one side, and like 8 or 9 or something like that on the other. So everything looked good. So it turns out that's a good amount. That's a healthy amount, right? Is that correct?
Yeah, she's right. That's a good amount. And that does sound about right. So that would be what we call your antral follicle count. That's one of the 2 ways that we typically will measure your egg quantity ovarian reserve. Is that right?
Yes. So that was thriving. I felt like I was already winning. I mean, I felt like I got a medal handed to me. And then I also had a genetic screening done too, to see where I was with things, and also my levels of, right? What is the other level?
Level. Yeah. So this is all the blood. The way that we do is with the antral follicle count and an AMH. And as Whitney said, a follicle count, of 8, 9, 17, that's very good. I would say that's probably even above average. So yeah, that's where we always sort of first start is kind of measuring egg numbers, and we do that. And then of course the next step is to select a sperm donor. And I find that everybody kind of comes in at a different place with this. Some people come in, they know everything already. They've already chosen their sperm donor. They know what their options are. And some people wouldn't even know the first place to look, or the first bit of information to have to select a sperm donor. So it doesn't matter where you are. We can meet you where you are. If you're at the very beginning, we start at the very beginning. And if you've already chosen your donor and you know how you want to use that sperm, we can help facilitate that as well. So again, I'm going to ask Whitney about her process in just a minute, but the first step really is selecting a sperm donor, because we'll need a sperm source. And there's really categorically 2 different kinds of sperm donors. Either you can choose an anonymous sperm donor through a sperm bank, or you can use a directed sperm donor. And a directed sperm donor is somebody who is known to you in some fashion, and the sperm has not yet been frozen. So when an individual or a couple chooses a directed donor, the donor needs to be screened. First of all, we need to make sure that donor has good sperm. Is there enough sperm to make this donor worth using? And so the donor would need to have a semen analysis, and Dr. Dovey did a really nice job explaining what is assessed in a semen analysis. So first we need to assess the quantity of the sperm, and then there's a full screening that happens that is aimed at preventing any infection, any exchange of infection. So that directed donor needs to have a full screening that includes a physical exam and a questionnaire and lab work. to screen out any chance of infection. So it's a little more complicated when you're using a directed donor. There's a recommendation even to quarantine that sperm for 6 months, and then to have the donor repeat the screening, and once again assure that all the screening for infectious disease is negative before all the frozen sperm, all the sperm that donor has collected can be released to us. So that's the typical recommendation, and there is some flexibility there, but that is the recommendation. And again, we typically recommend some legal contract in place if this is a person who is known to you. Now, when you choose an anonymous sperm donor, that screening has already been completed. So the sperm is available immediately, but it's not as though those steps weren't undertaken. It's just that they were already previously done, and now the sperm is frozen at the cryobank. And there's multiple cryobanks. And so that's kind of technically what you need, how, the different differences between the two donors. I'm going to actually spend some time, there's a couple other things we use to help you. I mean, the choice of a sperm donor is very personal, and I'm really going to ask Whitney a lot of questions about this because I think it's a big deal, and it's very personal. And there's a lot of things that will come into play when you make this choice. Now, as far as medically, the things that we'll use to help guide you, there's two big things. There's something called CMV, which is a virus called cytomegalovirus. It's a virus that 80% of us have been exposed to, and you wouldn't know if you had because it may just cause a common cold. So when you start to look for a donor, they will tell you this, what we call the CMV status of the donor from the sperm bank. And if the donor is CMV positive, it just means that donor has had CMV and they had a common cold, and it didn't make them sick or very sick. So we check every female who's planning to use donor sperm to see if she is CMV positive or negative. So if you're CMV positive, it means that you have immunity, right? You had the virus, now you have antibodies, you're immune, and you can choose a CMV positive or negative donor. And if you're CMV negative, you've never been exposed and you don't have antibodies, so we typically recommend that you choose a CMV negative donor. The other thing that you'll see when you look at the donor's information is whether or not they carry genetic diseases. So Whitney just mentioned, and we'll let her go into it a little bit more, she had genetic screening. So some of these donors will test positive for these silent mutations. So it could be cystic fibrosis or diseases you've never heard of, and you don't need to rule them out as donors just because they test positive for some of these genetic mutations. You just want to make sure that you're also not a carrier for any of the diseases that this donor tested positive for. So that's kind of, again, that's a lot of detail, and it's sometimes confusing. We end up going over it a few times and walking you through it, but I'm going to let Whitney tell us a little bit about her process. Did she, how did you decide to use anonymous versus directed? Let's start there.
Okay, well, I just want to say I always knew I wanted to enter the journey of motherhood and hopefully successfully become a mother. And my entire life, I said to myself 100%, I will use somebody I know. I need to see them. I need to feel their energy. It was incredibly important to me. So I thought, it was just something that it was priority to me. But when I established my timeline last year, that was really unwavering to me because I'm 37. And I really started weighing what was more important. And I noticed, in order to fulfill this dream, and I noticed that using a known donor, for me, this is all my personal experience, for me, it just threw a lot of moving parts in that I didn't want to deal with, nor did I need to deal with, because in learning about this, this is the biggest, getting pregnant, conceiving is the biggest kind of hurry up and wait scenario. You are basically trying to time this process down to this incredibly small window. You're trying to get all the planets in line in your uterus, and then get it down to this small window, and then get it in there and make it happen. Now, if you try to add a man to that equation with a tight timeline, I discovered that for me, it was challenging because you also have to explain to them how women's bodies work. because I started noticing that they were like, well, I'll be in town these days. Does that work? And I'm like, no, I'm not even ovulating that week. And they're like, well, can't we just try anyway? No, that's not how it works. So for me, nailing down the donor was challenging, and I started looking at different donors. And then I found someone, and I thought it was a go, and there was schedule conflicts and this and that. And I noticed that every month it kept getting pushed back, because if you miss that window, you got to go the next month. And before you know it, your timeline is closing. And then I also noticed that questions, and this again was just for me, questions started coming up about involvement. And so although I had certain parameters I was comfortable with, it started getting to a point where I thought, you know what, this is my journey. I'm going to go ahead and choose I'm going to go the anonymous route. I'm going to look into donors that way, and just see, try my best to do my due diligence, to feel their energy, feel their vibe, learn everything about them, and just go with my gut, and know that what I create, regardless, will be, a product of that like magic and beauty. And when I started looking, it's definitely, it can be an arduous test, but if you look at it as exciting, it's really exciting. And there's a ton of options, and it can be fun, it can be fun to look for. And, for me, I realized that I could kind of meet halfway on things. And it went from being important to knowing the person, to, for me, being important or imperative, really, to have an open donor at the bank. So that just means that when they're 18, they can contact the donor. It also opens them up to a sibling pool of sorts, where they can reach out to other offspring that were conceived via them. And that was really important to me, because, I think that the concept of family structure is, as we all know, as members of the LGBTQ community, it's constantly shifting and moving, and it is what we created. And that's what's really important to us and essential to us. So I thought that was a really cool component of things. And that really fulfilled that aspect that I was really craving, which was, if they have questions, if they want to feel included in something bigger than themselves, it was just important to me. So I got that satisfied, and I could close in that window that I needed and get the sperm here on time and deliver it and get it in there. And voila, almost 4 months pregnant.
That's great, Whitney. So a couple other things. So once you decided to use an anonymous donor and you started to look, what kind of information is available to you when you start to go to your cryobank's website? What kind of information do they give you? And then what did you do with that information? How did you decide this information is important to me, this information is not important to me, this is a priority? How did you decide those things?
Right. So for me, I switched cryobanks. I got inseminated twice, 2 different times. The first one was not successful. The second one obviously was. And so for me, what was important, obviously, because I did get my genetic screening done, I would first look at, out of 274 things, I had one potential mutation, or what you call it, a fairly insignificant one, that seemed to me. But I would just cross-reference and make sure that donor didn't have that. And then, rule that out from there. So now I'm moving on to the next step. And, I would look at what was really important to me. Obviously, you'll see the photos. And with Seattle, I ended up using Seattle Sperm Bank, and they only have child photos, but everybody has photos. So, you obviously, as you're scrolling, you're a human, you get more attracted to certain ones that resonate with you. But for me, a very important component was the audio interview. I found that was the best way for me to gauge just how, if we vibed energetically. It was similar to what was important to me initially. And my donor that I chose, words really just resonated with me. His humor resonated with me. I would read through, you know, they're very in-depth. They are super in-depth. 9 out of 10 guys that go in do not get approved for this. And they also have to commit to a year in advance. And most of these guys are going in 3 times a week. So they know these guys. Like, it's not just some random Joe off the street coming in and like doing his thing in a room and leaving. You know, they are vetting these guys. They need references. Everything is being cross-checked and everything like that. So it's a very thorough process. So, you know, that was a concern of mine as well. But after doing my research, I really found out that these guys are incredibly vetted, and probably more vetted than if I used a known donor, AKA a friend of mine, who, you know, I would only know in a certain sphere of things. So yeah, I would look at their health history, their family's health history. But like I said, a lot of these guys are already so clear of so many things that, you know, you could kind of jump ahead to, you know, qualities they possess, hobbies, interests, you know, they go into their emotional past, their stories, and you can just kind of gauge, you know, how well you think that they click with you. Like for mine, it was just like, he was a vegan guy with a great sense of humor, and I was sold, you know, amongst other things. But yeah, it was a process. But once I found, you know, I used a different donor for the first insemination round, and it was almost like I knew inside, like he wasn't the one. It was strange. And it didn't work. And then this guy, I just knew it. Like I felt it inside of myself. And you know, when it arrived, it was like a personal experience. Like I talked to the sperm. Dr. Brower can attest to the fact that I like held the little vial and was like, you can do it. Because you want to like put your energy into it. I don't know, I'm big on energy, and that was a big thing for me. But they are incredibly thorough. These sites are incredibly thorough and personal and in-depth, and they make you feel as comfortable and confident as possible going into the process.
That's great. Thank you. And so you also mentioned about being an open donor. So can you tell us, I mean, what was it made sort of your understanding? You mentioned it, but how did you decide that? And is it very clear when you look who it would be an open donor versus a non-open donor? I think that's a really big deal to a lot of people.
Yeah. So it will say clear when you put in your specifications, you can click open ID or anonymous. And then it'll wean them down. And so anonymous just means they're making their donation, and then that's it. The offspring won't have access to them when they're 18. And some people go for that because they want to keep it very disconnected. For me, like I said, it was really important for the potential, if the desire was there, for accessibility. And so it was very important for me to choose an open donor. So the open donor just, you know, it means that they can, like I said, be contacted when they're 18, and also gives access to a sibling pool, at least with Seattle Sperm Bank. And also in the audio interview, they ask them about it. So you can hear firsthand it come out of their mouths about being contacted or what that means to them, and kind of gauge, you know, where their head is at, which was important to me because I wanted to know if they actually thought about that, like on a real deep basis, because you have to think, where are these guys going to be 18 years from now? You know, I don't know where I'm going to be. So it's like, where are they going to be? Are they going to be with another partner who they have kids? Is she going to be, or he going to be okay with it? And what is that going to look like? So I felt listening to their responses, and if they were very practical, had a very practical response as opposed to an emotionally kind of derived response, it made more sense to me, and my donor did, and just hearing the comfortability that they would kind of discuss that, you can tell if somebody's kind of faking the funk, to be honest, and that's why I think there's such importance in the audio interviews of things. So that was good.
And then you also mentioned siblings. So did the cryobank give you information about the sibling donor registry? And what kind of information were you given about being able to contact siblings from your donor?
Yeah, so basically they said that each donor is able to contribute to 25 families And then that's the max out for them. And again, when I say this, I'm speaking specifically for Seattle Sperm Bank. I'm not sure if it's like this universally, but they max out at 25 families. So of those families, they would get access, if they so chose to essentially like a private group chat of sorts, a digital chat, and you can also reach out to the bank directly, and they'll help facilitate that. And so, yeah, for me, that was an added bonus. I actually didn't even know about that until I started the process, and I heard about that, and I was just, again, it goes to the redefinition of family, and I think that that's really important in this day and age and within our community. And, as a single mom going into this, now at least, and just being a single mom with one child, I think for me, it was it was an added benefit to be able to potentially open up their world to other extended family or other extended, if they have questions, because all kids have questions. They want to know. I mean, there's an innate curiosity. So being able to assist in that in any way possible was important to me, and I really like that.
Yeah, I think that's great. And I think that, Whitney's talking about a lot of things that you may not have thought to even think about. Like she just said, she hadn't really thought about the sibling donor registry or thought about connecting with other individuals who had created babies from her same sperm donor. So, a lot of times any type of third-party reproduction, no matter what your situation is, starts with counseling. So I think it's always a good idea to just start thinking about these things and what are the questions and where do you stand? Because, Whitney has felt like she, for her child, do you know what kind of baby you're having yet?
The gender?
Yeah.
I do. And I'll tell you guys only.
Do you know?
I'll tell 159 of you only, because I said on Instagram the other day I wasn't going to say it. So I'm going to say it now. It's a boy.
Hey! So exciting. So the choice for Whitney's son to know his half siblings, and that may be something that's exciting to you and fits into your concept of family, and maybe something you're not interested in at all, and both are completely fine. I think it's just important to know that that's a question and to think about where you stand. I have a handful of couples that know. We have a couple who's actually coming back for baby number 2 right now, and their daughter is probably 3, and there's probably 4 or 5 other half siblings in Los Angeles, and they get together routinely, and the families have all become very connected and really offer. There's they have sleepovers. And the siblings all, that's part of their story. These little kids, even a 3-year-old, she has some concept of how she was conceived, and these are her half siblings. And so at the age of 3, you don't know any different. So that's her concept of family, and they're at each other's birthday parties, and it's really cool.
Yeah, because I feel like they would all share this unconventional of sorts, backstory and narrative, and yeah, I just think it really expands the normalcy of it, the concept of normalcy. So yeah, it's really cool.
Yeah, that's cool. Thank you for sharing all that information. So the next step, right, is so as a female, you have your own eggs, right? You select a sperm donor, whether it's an anonymous sperm donor or a directed sperm donor. You have a sperm donor. I should take a step back and say everything that I just described really was just talking about how we do it in a clinical setting, right? So Whitney, when she was talking about using a directed donor, it sounds like you can use a directed donor without a physician, right? So it requires knowing when you're ovulating and using fresh sperm at home. So doing vaginal inseminations at home, which just essentially involves having somebody produce. There's no screening, there's no quarantine, you do it, there's no doctor, right? So you can absolutely obtain fresh sperm from a directed donor. I would still advise you to have some sort of legal arrangement ahead of time and do these inseminations, track for your ovulation, do inseminations at home. Again, we're not typically involved. So what I was talking about was what we do, and we do it here in the clinic. So then once you have a sperm source and you have eggs, then you have to decide where this pregnancy is going to be housed. And you know, for Whitney, she's doing this on her own. So she was using her own eggs and her own uterus. Sometimes when there are two, you know, when you have a same-sex female couple, there are actually two choices, right? So there's two different uteruses that can be utilized. And so then the next decision is, okay, which eggs are you using and which uterus will you use? And then it makes it, there's kind of a multitude of options. If you are using the same, so if you're going to use the uterus of the person whose eggs you are using, then you can be a candidate for an insemination. And so that's what we did with Whitney, right? You can take the sperm, the donated sperm, and put it right inside the uterus at the time of ovulation. And it can be done in a completely natural cycle where there's no medications required. So we just need to figure out exactly when you're ovulating and put the sperm inside the uterus at the time of ovulation. And that's what we call a natural cycle insemination. Sometimes for various reasons, we will use medications. We can use medications to stimulate more than one egg to develop at a time. So depending on an individual's age or their ovarian reserve, we may say, hey, you know what? Let's give you some oral medication to get you to release 2 eggs at a time or more than 1 egg at a time to increase the odds that a conception occurs. So Whitney, I remember what you did. Do you remember what we did for your cycles?
Yeah. So the first time around, we did natural cycles. So no assistance of drugs or anything like that. I did, however, take a trigger shot. Again, something I knew nothing about. I did not know about LH surges, or anything like that. So basically, and I'm sure Dr. Brower can correct me if I'm wrong or expand upon this or something like that. But so the natural cycle, my natural cycle started, but the LH trigger shot is basically you take it timed. So I went in and got an ultrasound and saw when my follicles were dropping, right? That you see where the follicles are dropping and they measure them. And based off of the size of it, she would tell me when to take this trigger shot. So I obtained the trigger shot. I had it. It's something that you inject into your stomach. And basically when you inject it, 36 hours from then is when your follicle will be fully ready to have the highest probability of having a successful insemination. Is that right? You did a really good job. You did it. So that being said, the first time around for me with the natural cycle was unsuccessful for whatever reason. So the second time around, obviously I also switched donors, like I said, but I decided to do the assisted version. And basically it was a pill that I take for 5 days. What is it called?
You take Clomid or Letrozole? Clomid.
So I took Clomid for 5 days, and basically that increases my follicle production, my follicle release. So I ended up releasing 3. That also increases your chance of multiples. So that's something you want to weigh in as well, if that's something you're ready for. I made it out the gate with just 1 successful, so that's good.
Hey.
Yeah, I would have been happy either way, but let's be real, overwhelming. So I ended up taking the Clomid and then went in, got the ultrasound. She measured my follicles, and then I did the trigger shot again, waited 36 hours, came in and did the IUI insemination. And again, like I said, it's such a hurry up and wait. It's so timing of things down to the hours, you know, and then you get in and you have all this, just to kind of like sidestep a little, you know, you have all this scheduling and time and this and that is going, and then you inseminate and then you're like, okay, great, what now? And they're like, you just wait. And I'm like, what do you mean? Wait for how long, you know? And that's the part that really starts driving you crazy, to be honest, because you're just waiting, because now you're adding up the timelines. Oh, there's up to 5 days for this insemination to be successful, take place, and then the implantation. And then also something to take into consideration that I learned is that if you take pregnancy tests too soon, you will still have the LH, potentially the surging in your system, and you can get false positives. And that is not fun. I got that in the beginning because I was impatient. And then even though I said I was going to have no expectations or get my hopes up, you do, because that's why we're doing it, right? We're doing this to hopefully have a successful pregnancy. So you could tell yourself all these things, but the reality is, you get naturally disappointed. So in jumping ahead a little, my recommendation for that is try to be as patient with yourself and the process as possible. I know there's a lot of hurrying up to that point, but after, just let it go into the ether and hope for the best. And that's what I tried to do as much as possible. I wasn't perfect. I did take earlier tests. Turns out they were positive.
That's great. And so I think, Whitney did a really good job explaining that. And the real key here, right, is making sure that we're doing the insemination when the egg is being released, when an individual is ovulating. So I like to use a trigger injection because it really allows us, we can say, okay, we measure the follicle based on the size, we know the egg should be mature. And I know if you give yourself this trigger injection, that you're going to ovulate 36 to 38 hours later. And it just really sort of allows us to perform a really well-timed insemination, and just one, because it's so well-timed. So, but other doctors may just have you check ovulation predictor kits at home and time the insemination that way. That's sort of really a style thing. And then again, as Whitney described, sometimes people will decide to take medications to release more than one egg at a time. And again, it is more typical that we would offer something like that in women over the age of 35 and certainly over the age of 40, or if people have done multiple natural cycles and not conceived. So those are typically the reasons why we would move on to a cycle with medication.
I just want to add something as well, which is that I just want to point out that I tracked my ovulation for a year in advance. With strips. And I noticed when I went I also had LH surge strips. And I noticed when I went into Kindbody and started getting the actual ultrasounds done, the strips were not 100% accurate. And so that's, for me, why I decided also to go, with some of the advice of Dr. Brower in terms of the LH, the trigger shot, because I knew that what I thought. So if I had been doing it with a known donor at home and things like that, I would have been missing my window essentially. And that would have been potentially a lot of wasted situations.
Yeah.
So for this, it really, you can physically see it. So just for me, it made me feel better being able to narrow it down so much and seeing it, because I knew these strips clearly were not actually 100% accurate.
Yeah. And they can be really confusing for people. And sometimes people just get anxious about them. And so if that's the case, then it is easy to take them out of the equation by using.
And also the ovulation strips are telling you, and if you don't know about your LH surge, you're tracking your ovulation without knowing about your LH surge, which is really what matters in terms of successful conception. So you're thinking, oh, I'm ovulating this day, so this is the day I'm going to inseminate, when in reality it's like 3 days prior or something like that. It's off the way that it's set up, the way that you think about it, in just doing it yourself.
Yeah. So then, again, Dr. Dovey did a really nice job explaining the process of IVF. So there's multiple reasons why a female might choose to do IVF. What autologous IVF is when the same person who carries the pregnancy is also the one creating the embryos. So sometimes IVF is required for a female to conceive, and I just sort of list some of the reasons there. Either there's been multiple failures with IUI cycles, and ultimately the decision is made to proceed with a more aggressive treatment with a higher success rate. If the fallopian tubes are blocked, typically if we're using anonymous donor sperm quality isn't an issue, because again, they've sort of been pre-screened for that. Sometimes older women will say, hey, you're telling me my success rates are whatever, less than 5% with an insemination, maybe I'm going to do IVF because the success rates are higher. So there's some reasons that autologous IVF might be done. And again, the process is the same as the process that Dr. Dovey described for donors. Again, everything that happens is sort of identical. Reciprocal IVF refers to the process of using one individual's eggs to create the embryo and then transferring the embryo into somebody else's uterus. And we do that not uncommonly as well. So some same-sex female couples will, if or at least one of their children, there may be one individual who desires they want to carry all of the pregnancies. And so one partner may choose to make an embryo and then transfer that embryo into her partner's uterus. And again, that is the process of reciprocal IVF. I don't know if I'll go into too much detail here. It is, as Dr. Dovey described, the process is identical. So the same injections that an egg donor would take, an individual doing either autologous or reciprocal IVF, whose ever eggs are being used, that's the person who takes the injections that are intended to stimulate the ovaries to make multiple eggs at a time. The eggs then come out. She showed us a beautiful picture earlier of how the eggs are removed from the ovary. The embryos are formed and typically then frozen. Genetic testing can be performed in the same way that Dr. Dovey described, and then you decide where will that uterus go, and it can go into this uterus of the person who created the eggs, or the uterus of her partner, if she has one and her partner wants to carry, or into the uterus of a gestational carrier if for any reason that individual or couple desires for a carrier or a surrogate to carry the pregnancy. And again, really the steps are identical to what was previously described. And then lastly, I think for anyone who is building a family, there are other means. So egg donation, which we've talked a lot about today, Dr. Dovey talked about it in the setting of males creating families, because again, they need to use an egg source. Sometimes females, oftentimes actually females use egg donors as well for various reasons. Advanced age, or they've, had multiple, a lot of times there has been some inability to achieve a pregnancy with her own eggs. And so a female may choose to then use an egg donor to conceive. There's embryo adoption. So what embryo adoption involves is essentially adopting an embryo. And when done through an agency, it's actually a real adoption where you create a personal profile and are matched with a family, and there may be an individual or a family who has created embryos. They are now family complete and are willing to donate their embryos to somebody else who's trying to get pregnant. And then you can adopt those embryos. The embryo can be transferred into your uterus, and then you can carry a pregnancy. Carry the pregnancy, deliver the baby, nurse the baby. I have two couples here in LA that both conceived. They're two different families, both of which who had really long fertility journeys and ultimately ended up doing embryo adoption, but they ended up adopting embryos from the same group of embryos. So their children are actually full siblings. And similar to what we were discussing, these families have formed a connection and meet routinely, and these full siblings that are being raised in different homes again, they're part of each other's family units in this sort of unconventional way, which is really cool. Embryo adoption with surrogacy, so that can be done if you're a female into your uterus or a surrogate's uterus, or if you're a male and you don't have a uterus, you'd obviously be using a carrier, but embryo adoption is available in that setting as well. And then there's always traditional adoption, which we don't necessarily facilitate here at Kindbody, but can sort of point you in the right direction if that's what's going to be right for you and your family. And I think that's kind of it. Again, the virtual consultation, we put this at the end, but it's always where we start, because it's so important for us to understand who you are and what your reproductive goals are, so that we can really help you and create a plan that works for you. And I think that's it. Whitney, did I forget anything?
I want to add that one of the main reasons that I initially chose Kindbody is that I just want to point out that they are a woman-owned and operated business, and to me it was important. And also just coming into their whole space in general, meeting everybody, the entire team, it's like so much like a family, and it was very warm, and people were very invested in your process. And I just want to add, doing this alone, it's a unique process. I never thought I would be doing it alone, and they really contributed to making me feel very supported and safe and celebrated. So that was important to me. So I really feel like it's important, for whatever means you go about doing it, choose a team or choose people that you really feel supported in, especially being members of, part of LGBTQ community, that was something that was important to me too. They really understood the verbiage and the importance of like different processes in your own brain and things like that. And if they got something wrong, like they love to be corrected, like authentically. So that was important too. So I just want to point that out and give you guys a little acknowledgement and accolades on that, so you don't have to toot your own horn. I could toot it for you.
We didn't ask her to say that, and just, you know, Whitney was super easy to take care of because she's so pleasant and so positive, and she was a pleasure to work with. So there.
Thanks. I'll take it.
And I think that's kind of it. We're going to take some questions. This is you, Tracy. You want to walk everybody through this a little bit, and then we'll do some questions?
No, absolutely. And Whitney, thank you for sharing. Now I don't have to bug you and ask you what you're having. So
yeah. This is a closed group, guys. So keep that information. We're part of a private crew, all 160 of us. Don't go spreading
the circle of trust.
Yeah, exactly.
I'm going to go on the internet right now. They'll be like, "Oh, Whitney's having a boy." Yeah, there'll be two flowers on your doorstep in like 5 minutes. So a lot of amazing questions, and I want to thank Dr. Dovey and Hina, who joined us, our PA, and Erica Keller, who's been madly typing in the chat box. But I thought this was a good question. If I had an HSG back in 2017 and have been recently trying IUIs that are unsuccessful, would you recommend doing a new HSG?
You want to do that, Dr. Dovey? You're muted.
Oh, sorry, unmute you. I'm like the mean mommy. I'm like, let me, oh wait, did you hit it? I'm so sorry.
So I would say, unless something dynamic, so the HSG, which we didn't really talk about, sorry, is a test that evaluates if the fallopian tubes are open and if the contour, the shape of the uterus is normal. If you're doing inseminations, the fallopian tubes do need to be open. And I would say, unless there's something dynamic that's happened, a surgery or an infection or something that could have subsequently blocked, something that caused disease or damage to the fallopian tubes, then I don't think that there's much utility in repeating it. What do you think, Dr. Dovey?
Can you guys hear me now?
Yeah.
Yeah.
Sorry. I kept saying mute, unmute. Yeah, no, I agree. I think unless something's happened since the last HSG, if the last one looked totally normal, it's probably unlikely that the tubes would become blocked unless, you know, like Meredith said, if you've had a surgery or you had like some sort of infection, gonorrhea, chlamydia, something like that, I would do it again if there's a risk factor, but otherwise it's probably not necessary.
I agree.
And I know we're gonna, because people are gonna probably start dropping off and be like, are they really talking for 98 minutes? But I do want,
sorry,
we can talk longer. Yeah, no. But I just want to point out before everyone, because I want to make sure that we share all the codes. So an amazing thing. So anybody, go back one quick. I just want to talk about,
this one?
Yes, there we go. We'll start there. And then, so if you put fertility awareness in your box in the discount code, normally a virtual consult's $150. So we're able to do it for $75. And then Rebecca is so amazing. We're doing a discount for IUIs, which is really awesome. So for $900 versus $1,200. And then here's the thing, just so you know, you don't have to, it's not something that you pay up front. The good thing is if you book your consult till the end of April, if you utilize that fertility awareness, if you just book it, you don't pay for it in the moment, you pay when you start utilizing the services. You can still, even if your appointment is in May or further out, you can still get the discount. So it's good to just get in there and put the discount, so then you're able to apply your discount. And then we're gonna go, Seattle Sperm Bank is super duper incredibly amazing, and they are offering a membership pass for a 3-month all access, and then also willing to do a complimentary donor consultation. And you send them an email, cs@seattlespermbank.com, and you put in the subject line kind body. So that's for the next 24 hours. So hot off the press, I would drop them an email right away so that you're able to access those discounts. And I'm really, Seattle Sperm Bank has been amazing to work with. They're so great. That's who Whitney worked with, and Dr. Brower can speak to having worked with them in the past as well. And so we're super happy to be able to share their discount with everyone. And so quick question too, to my lovely my Roots team over here, Brooke. People are asking, what is about the average price of a gestational carrier? Oh, and she's muted because Mean Mommy did it again. Sorry. Okay.
I'm here. So we're looking at all in, so including the agency, the doctor, IVF for the surrogate, attorneys, and the surrogate herself. Most of our clients are spending about $150,000 total.
And if you're doing the donor part yourself, so if you don't need an egg donor, so say if this was a same-sex female couple that needed that, so the cost of the surrogate is about, and I'm sorry, go ahead.
Sure. So it depends on where you're looking and located. Sometimes for our agency specifically, we don't change the compensation of the surrogate because we feel like she's doing the same thing if she lives in Kansas or California. California has the longest withstanding laws protecting both parents and surrogates. And so California is sort of the mecca of surrogacy. If you think about the way that the US looks, there's red states, yellow states, and green states as it relates to surrogacy. And green states are, we understand that you want to be a parent. It doesn't matter that you have a surrogate. You are going to get a pre-birth order while the baby is still in uterus that says parent 1, parent 2, or just parent 1, you're the parent. That's it. There's no mention of surrogacy. In yellow states, it's we'll let you do it, but there's a caveat. So sometimes that's related to same-sex couples. Sometimes that's related to, yes, you can be the parents, but it has to be post-birth, meaning after the baby's born. Sometimes it has to be a step-parent adoption for the second parent. So those are sort of the yellow states. And then red states, we're so happy that they're dwindling quickly, but they are saying absolutely not, don't do it here, don't have a surrogate here. New York has been a big one of those for a long, long time, and just literally 2 weeks ago, they changed over. So starting January 2021, or actually April 2021, we will have surrogacy open in New York, which is huge.
Yay!
Yay! Go New York.
Yeah.
It is from a surrogate perspective, it is varying cost depending on the doctor that you choose, the agency that you choose. If you're using a repeat surrogate, somebody that's already carried for another family, that can be more expensive. So there are varying costs in surrogacy, and we're happy to chat if people want to give us, some time, and we're happy to discuss like specific to you what you're looking for and how that's going to vary.
Perfect. Thank you so much, Brooke. I know we have a lot of questions, and just if you have a specific question that we did not answer, please feel free to send your question to navigator@kindbody.com, and we will address every question. Just to let you know, this talk, a recording of this talk, we'll send you in an email so that you're able to take a look at the slides. There's a lot of information to try to take down at one time. And then we'll send a link, and then we'll also have it on YouTube so that we can share the information. So please feel free to point people in that direction, because in earnest, we're really here to provide information. And I really, really want to thank Whitney for joining us tonight. I want to thank our friends at Seattle Sperm Bank for offering the discount. I want to thank my wonderful friends at Roots Surrogacy Agency. And thank you, Dr. Dovey and Dr. Brower. We're in earnest so happy to be able to put this together for everyone tonight. And we want to thank everybody for joining us. And I'm going to be bugging Whitney. I already told Whitney once she has a baby, we're strapping that baby to her. We've got the Kind Body bus. And we're saying national.
We're hitting the road.
Yeah, exactly. So we're super excited to be able to have this inclusive discussion. And again, like Whitney said, we're always open to learning and talking and figuring out what works best for you and how we can get this together, because we believe that everyone deserves the opportunity to become a parent, and that's why we're all here and why we all do what we do. So thank you so much for everyone for joining us. I saw some emails in there. We're starting the support groups. I will reach out. If you're, the best thing to be is join our mailing list. We really do our very best to not spam anybody and only give you great information. And so we'll let you know when new events. We're starting a whole new community for Kind Body. So there's a lot of good things going on. So again, thank you everyone for joining us. And it's made us very happy to see some of the same faces on multiple events. so that we feel like we're not alone every night when we do this. I'm like, there's our friend Joanna from Texas. Like we've got a good group. So thank you everybody again, and have a wonderful night. And we look forward to seeing you in the future. So thank you.
Thank you, everybody.
Thank you, everybody. Thanks, Tracy.
Thanks, Tracy.
Of course. I'm going to keep it on for a second just so we can make sure I have everyone's emails and questions. So feel free to log off.
Okay.
Thank you.
Bye, everybody. Thank you. How do I get out of this thing?
I know.
I know this is the awkward time.
In the kitchen. Yeah, exactly.
All right.